So what is sepsis? The CDC defines sepsis as the body's extreme response to an infection. It is life-threatening, and without timely treatment, sepsis can rapidly cause tissue damage, organ failure, and death. Sepsis happens when an infection you already have in your skin, lungs, urinary tract, or somewhere else triggers a chain reaction throughout your body. Sepsis and septic shock are major healthcare problems, affecting millions of people around the world each year, and killing as many as 1 in 4. Similar to polytrauma, acute myocardial infarction, or stroke, early identification and appropriate management in the initial hours after sepsis develops improves outcomes. In the U.S., there are more than 750,000 new cases of sepsis each year, and the incidence is increasing annually. The infection tends to spread quickly and is often difficult to recognize. The mortality rate associated with severe sepsis remains unacceptably high, approximately 28 to 50%. These percentages increase with the number of organs affected by the infection, with mortality rates reaching 75 to 85% when 4 or more organs fail. Clinical definitions related to sepsis. Sepsis is defined as 2 or more positive SIRS factors. SIRS, which is a systemic inflammatory response syndrome, is characterized as a temperature greater than 38 degrees Celsius or less than 36 degrees Celsius, which is 100.4 degrees Fahrenheit or 96.8 degrees Fahrenheit. Heart rate greater or equal to 90 beats per minute, respirations greater than or equal to 20 breaths per minute, or white blood cell count greater than or equal to 12,000 or less than or equal to 4,000, or a 10% increase in mature neutrophils. Sepsis typically begins with a systemic inflammatory response syndrome, the body's response to an insult that results in activation of the immune response. This inflammatory response is the body's way of attempting to maintain homeostasis. While infection is one trigger for SIRS, there are also non-infectious causes, including trauma, burns, myocardial infarction, or inflammatory processes such as pancreatitis. Therefore, it is possible for your patient to have SIRS without being septic. Sepsis presents when a patient has SIRS plus a documented infection. This infection can be caused by bacterial, viruses, or fungi. Severe sepsis is defined as sepsis complicated by organ dysfunction, hypotension, or poor perfusion, and is considered the most common cause of death in non-coronary critical care units. Poor tissue perfusion is evidenced by an increased serum lactate level or slow capillary refill. Lactic acid is produced as an end product when tissues do not receive adequate oxygen, resulting in anaerobic metabolism. Therefore, a serum lactate level greater than 2 is an indicator of hypoperfusion and organ dysfunction. So, how do we treat sepsis in the emergency department? The initial management of the ED patient follows a simple, well-defined algorithm regardless of the etiology of the patient's current illness. The ABCs of resuscitation instruct practitioners to evaluate the airway and, when required, establish a patent definitive airway. Evaluate for adequacy of breathing and rapidly assess circulatory status. Emergency department's evaluation of critically ill patients also includes rapid establishment of adequate IV access, which typically includes 2, 18, or 20 gauge IVs, large bore IVs, surveillance laboratory work, initiation of fluid boluses to reestablish preload, and obtaining appropriate diagnostic studies. With special focus on the severe sepsis patient, initial management should include blood and urine cultures, source control where appropriate, and rapid administration of appropriate broad-spectrum antibiotics such as gentamicin, penicillins, ampicillin, cephalosporins, cefalozolin, vancomycin, nafcillin, or oxacillin. Protocolized resuscitation of patients with severe sepsis and septic shock have become a widely recommended standard for patients with fluid refractory septic shock. Given the long ED boarding times in healthcare systems plagued by overcrowding, hemodynamic monitoring, and physiologic optimization have become a necessary practice in acute care settings prior to transfer to an ICU. Volume resuscitation, which is 20 to 30 cc's per kilogram of normal saline or lactated Ringer solutions over a 15 to 30 minute period, should be initiated as soon as hyperperfusion is recognized, regardless of the patient's location in the healthcare system. So what is sepsis CMS core measures? In order to be compliant, you must meet all measures. It's an all or nothing deal. With severe sepsis, this includes the 3-hour presentation, measure your serum lactate, obtain blood cultures prior to antibiotics, and administering the antibiotics. Within 6 hours of presentation, you must repeat your serum lactate if initial lactate is greater than 2. For septic shock, within the 3 hours of presentation, you must measure the serum lactate, obtain blood cultures prior to antibiotics, administer antibiotics, and resuscitation with 30 cc's per kilogram crystalloid fluid. Within the 6 hours of the presentation for septic shock, you must repeat your volume status and tissue perfusion assessment, vasopressor administration if hypotension persists after fluid boluses, and a repeat of assessment of volume and status and tissue perfusion is required for all patients with septic shock. So, what are we doing as new implementations in the ED for sepsis management? In our ED, we are now using the non-invasive hemodynamic monitoring, using the Edwards EV1000 with the ClearSight finger cuff, and the Qsofa, which is the Quick Assess Sepsis Related Organ Failure Assessment. Why do we need these implementations? The Centers for Medicare and Medicaid Services now require hospitals participating in inpatient quality reporting programs to collect data for the severe sepsis and septic shock, severe sepsis and septic shock management bundle measure, NQF pound 0500. With the implementation of this measure, CMS will be able to gauge if care of severe sepsis and septic shock patients is improving. Compliance with this measure will determine payment starting fiscal year of 2017. The 6-hour bundle was recently updated to include the dynamic assessment of fluid responsiveness with either a fluid bolus or a passive leg raise fluid challenge. With the dynamic assessment, cardiac output or stroke volume must be known in advance and after the maneuver to calculate the percentage volume responsiveness. Edwards offers non-invasive and minimally invasive monitoring solutions with critical dynamic and flow-based parameters to help you make proactive clinical decisions while also meeting the NQF requirements. Early recognition is critical for timely intervention. It is critically important that patients are diagnosed as soon as possible, as the mortality increases if the patient does not receive the appropriate intensive care. So what is the Qsofa? The Qsofa score, also known as QuickSofa, is a bedside prompt that may identify patients with suspected infection who are at a greater risk for a poor outcome outside the ICU. It uses 3 criteria, assigning 1 point for low blood pressure with a systolic blood pressure less than or equal to 100, a high respiratory rate which is greater or equal to 22 breaths per minute, or altered mentation, Glasgow Coma Scale less than 15. The score ranges from 0 to 3 points. The presence of 2 or more Qsofa points near the onset of infection was associated with a greater risk of death or prolonged intensive care unit stay. These are outcomes that are more common in infected patients who may be septic than those with uncomplicated infections. Based upon these findings, the Third International Consensus Definitions for Sepsis recommends Qsofa as a simple prompt to identify infected patients outside the ICU who are likely to be septic. Initiating hemodynamic monitoring, early detection and management of sepsis patients is critical to improving survival and reducing the economic burden of sepsis. Edwards Life Science Hemodynamic Monitoring Solutions offer advanced, flow-based parameters to help you detect sepsis early, guide treatment evaluation, and then comply with the CMS NQF bundle requirement. So the hemodynamic monitoring is a simple, non-invasive approach to monitoring key hemodynamic parameters: stroke volume variation, cardiac output, systemic vascular resistance, and continuous blood pressure. Edwards Life Sciences ClearSight system is comprised of the ClearSight finger cuff and EV1000 clinical platform. The system presents the stroke volume variation, cardiac output, and continuous blood pressure clearly and simply on the EV1000 monitor. Easy to use touch screens allow selection of the parameters most meaningful for each clinical situation. This intuitive display of fundamental information minimizes unknowns and allows you to more accurately determine your patient's fluid status. Flow parameters provided such as stroke volume and stroke volume variation have been shown to be more dynamic and sensitive and specific for predicting fluid responsiveness than the conventional pressure-based parameters. These parameters are Edwards ClearSight finger cuff and or FlowTrack sensor can be used to measure flow-based parameters continuously prior to, during, and after the fluid administration portion of the 3-hour bundle. Used as a standard for monitoring in space for decades, non-invasive technology has been extensively validated against gold standard monitoring technologies. Several studies have validated the ability of non-invasive technology to reliably track continuous blood pressure, absolute cardiac output, and continuous cardiac output. The simplicity of the ClearSight system gives you non-invasive access to automatic, up-to-the-minute hemodynamic information for a broader patient population. Finger cuff provides up to 72 hours of valuable hemodynamic insight, but continuous monitoring on one finger is limited to 8 hours. Uninterrupted monitoring over 8 hours is possible using 2 cuffs on 2 fingers. To accurately mirror arterial line output, real-time finger pressure measurement is performed 1,000 times per second utilizing the volume clamp method to be implemented. ED providers and nursing staff will be required to attend a 30-minute competency demonstration of the EV1000 after completing the online instruction portion. ED nursing staff will be required to watch a short online video explaining how to perform the Q-SOFA in their daily assessments, and how to document it in the patient's chart. There will be an automatic screen that will generate with each patient to do a Q-SOFA screening per shift. Staff will also receive a badge card with the Q-SOFA instructions on it for quick reference during assessment. It is important to implement tools such as the Q-SOFA and the EV1000 hemodynamic monitoring system as early interventions in the ED so that we are able to recognize signs of sepsis and organ damage, as well as ensuring that the patient is receiving the adequate amount of fluid resuscitation without ensuing complications and can be corrected in the safest manner. Implementing these strategies will not only decrease sepsis mortality rates, but reduce the economic burden of sepsis, decrease length of stay in critical care units, and allow for the better outcomes